Hello, my friend, and welcome to another episode of I Love Being Sober, sponsored by Camelback Recovery, Arizona's preferred mental health and addiction treatment option to help people get on the path or stay on the path to recovery. My name is Tim Westbrook, and I'm the CEO and founder of Camelback Recovery here in the always sunny and always sober Scottsdale, Arizona, where my team and I, over the course of many years, have helped thousands of people to stop their suffering and continue on their path to recovery. The purpose of this podcast is to come clean with all of the misinformation that's out there about recovery, addiction treatment, mental illness, and the strategies to thrive in life. Visit camelbackrecovery.com to learn more about our treatment strategies for alcoholism, drug addiction, or mental illness. And we even offer recovery coaching so that you can enjoy the happiness and freedom you've always searched for. Today, I'm here with Taran Good Ballet, and Taran is a PharmD and mental health pharmacy is her focus. She loves helping people achieve better mental health through many modalities, and we will discuss the use of medication-assisted treatment, also known as MAT, and the role it plays in mental health and addiction recovery. Taran, welcome to the show. I'm so glad to have you here.
Yeah, thanks for having me. I'm excited to talk about this.
All right, awesome. So let's see here. So what's a PharmD and what's the difference between a PharmD and a pharmacist?
Okay, so all pharmacists starting in 1999 actually have to have the PharmD education. And then so it's a Doctor of Pharmacy. You go. So like I got a bachelor's degree in biology from ASU, and then I moved on to get the Doctor of Pharmacy from Midwestern here in Arizona. And you have to have that education to go on and get licensed as a pharmacist. And you don't have to get the PharmD and then be licensed, but you do have to have the PharmD to be licensed, if that makes sense. So that's what that is, the Doctor of Pharmacy. And you can do a variety of things with that education. Some people go and work for the pharmaceutical companies. Some people do some extra education and then get into more of a clinical role. And then some people go and work in the retail pharmacies. So it's a huge spectrum that you can do with the Doctor of Pharmacy.
And what specific incident inspired you to become interested in becoming a pharmacist?
From a young age, I think I knew I was going to go into the medical field in some way. I wasn't sure what. I think for a long time, I thought I was going to go to an MD program. And then sometime in high school, I started hearing more about pharmacy and medications, and I really loved the chemistry aspect, the medication aspect. There was just something in my mind that drew me more to pharmacy instead of doing the physician route. So that kind of just decided, and I went with it.
Okay.
Yeah.
And so now medication assisted treatment is something that I know you're passionate about. And
Yeah.
there's there's lots of people that agree with medication assisted treatment. I think more today, 2022, at the time of this recording, there are more people that see the benefits of medication assisted treatment. And there are other people with the old school of thought that abstinence is the way to go. So what gives you the right to claim you are an expert when it comes to medication assisted treatment?
So I've been working in mental health care for about 4 years. And with our training as like clinical pharmacists, the Doctor of Pharmacy, we go in depth. We have the most pharmacology training out of any of the medical professions in their education training. So we do pharmacology in basically every therapeutic category. We do it for 3 or 4 years, depending on which program you're in. And other fields do maybe 2 semesters, depending on if it's, a physician, if it's the DNP, if it's the PA. So they do about 2 semesters, and we do pharmacology training our entire 3 to 4 years. So we get a very in-depth perspective on things. And we in my mental health training while I was in my program, and then afterwards in my career, I've just taken a deep dive and had experience. I was 2 years at a pharmacy with SMI patients specifically, and a lot of them were using substances. And now I'm over here at Camelback. We focus a lot on rehabilitation, of course, of substance abuse. So I have a plethora of experience with medication assisted treatment. And, I am very passionate about it. So we can get into that because I really think it is so helpful and beneficial to recovery.
So let's go back. What got you interested in mental health? I know you said SMI. For people that don't know, SMI is severe mental illness.
Yes.
What got you interested in mental health specifically and addiction recovery?
Yeah. So growing up, it wasn't the most functional childhood experience, I would say. There a long line of substance abuse in my family, and that comes with some mental health issues. So I was the youngest of four kids, and I think I took a role of stepping back and seeing everything in front of me. And I always thought, like, it doesn't have to be this way. Things can be different. And just a really strong curiosity about it from a young age. So when I was in my pharmacy program, I didn't even know all the places I could go with my PharmD. But when I realized that I could do important work in the mental health field, it was immediate because of that curiosity from such a young age, that substance abuse that was, I don't want to say like a plethora, but it was prevalent. And I grew up around it, and I had grandparents, great grandparents. So with that substance abuse, then none of them had treatment. That causes mental health problems. It causes dysfunction. So, knowing that as I got older and seeing that there's help, all you have to do is get help.
Right.
I wanted to be part of that help so that people who, either are looking for the help or don't know about it, I want to be part of helping them find it and get there.
Awesome. Awesome.
Yeah.
That's great. And my experience is that most people that work in addiction recovery, mental health have their own experience, whether it's their own experience or experience with people close to them. So that's good to know. And I'm learning more about you as you mentioned earlier. You are at Camelback Integrated Health and Wellness, and you're providing services for us on that division of our company. So going back, okay, as far as your education with mental health and medication assisted treatment, so you have your education and everything that you learned in school.
Mhm.
So what about the continued education? What are you doing to stay? Because things are changing constantly,
Yeah.
right? There's new, like MDMA guided therapy, I think is going to become legal in January 2023, right?
Yep.
And
Yep.
there are other psychedelics that are on the horizon that will be used for mental health and for addiction recovery. So what are you doing to stay educated and on the forefront of medication assisted treatment?
Yeah, I do CEs all the time. I'm always looking for new certificates. And like to your point, because of how quickly things are changing, a year ago, I could not find any medication assisted treatment certificates for pharmacists. And now I'm actually in the process of completing one. So they're coming up with new trainings constantly. And I think this is a huge role for that pharmacists can be a part of, that they're not necessarily a part of yet. There's a lot of clinical pharmacists in institutions, hospitals, on those psych floors in the institutions, but getting them into, outpatient clinics and rehabs because of their knowledge and their continued training, I think is really important. Um I have been looking for some of those like psilocybin and MDMA trainings. We don't have those yet. So I do follow a lot of like physician CE continuing education type groups, and I follow substance abuse clinicians who put out continuing education for that so that I can still get that. But on the doctor of pharmacy, because we have a little bit different accrediting bodies for our CEs, I can't necessarily do them and get credit for it, but I'll still look at them and do them just on the side so that I can stay up to date on all the new things coming out. Because yeah, you're right. There's so much new stuff coming out, and I'm really excited about it because the data is showing really great efficacy.
Right, right, right. They've been testing for many, many years, which is appropriate and
Yeah,
necessary.
right.
Okay, so who's a candidate for medication assisted treatment?
Anyone who has a diagnosis of a substance abuse disorder or substance use disorder, I apologize, and they're immediately a candidate. We're gonna,
So
see
why are they immediately a candidate?
because they have this use disorder. That means their brain chemistry, they can benefit from it is why they're a candidate. They're in a category where we have medication that we can use and they can be of benefit for them. So, they'll be in that candidate category. There may be some things with each individual that maybe decrease their candidacy depending on, the substance of choice. We don't have necessarily medications for every substance that is considered medication assisted treatment. We have a lot of medications that are being researched for different substances. So that may depend on what substance they use. But as we see with a lot of people who use substances, they kind of use across the board. They don't necessarily always just have one. So if they have a use disorder on a substance that we have a medication that we know can help with that and help them get off that, then they're a candidate.
Okay. So I guess you said people with substance use disorders are candidates. Who else is a candidate?
For medication assisted treatment, really just the substance use disorders. There's other, yeah, because the medication assisted treatment category is specific to substance use. And so it would be a diagnosis of that to use some of these MAT therapies.
Okay, so you said there's different substance use disorders, right? There's different substances.
Yeah.
What is appropriate for what?
Okay. So we have now the three main like recognized MAT therapies would be methadone, buprenorphine, and naltrexone. And you'd definitely with methadone and buprenorphine, it would be an opioid substance use disorder. That doesn't mean they only use opioids. They may use opioids and everything else in the spectrum, but we wouldn't put anyone on methadone or buprenorphine MAT therapy if they've never used an opioid. And then naltrexone. Naltrexone is a
And
wonderful.
just for people that don't know, what's the other name for buprenorphine?
So suboxone, Sublocade,
Right.
Subutex. Yep. There's a few brand names with it.
Okay.
Yeah.
It,
And then,
it, and so before you talk about naltrexone,
yeah.
I guess talk about naltrexone, and then I have a question about the Sublocade and Suboxone.
Okay, sure. So naltrexone, that one can be used for quite a few different things. It actually has some data behind not just opioids and alcohol, but actually can decrease cravings. The way it works in the brain with like gambling may work for some of the other substances with cravings. Right now, it's mainly for opioid use and alcohol use.
How does naltrexone work?
So it blocks called an antagonist. And what it does is it binds tightly to the opioid receptors. And so it blocks the cravings and it also keeps if any opioids come into the system, if they use at all, it blocks the effect. So you can't get high, you can't get drunk, you can't get that good feeling of alcohol. Um, so it can decrease cravings that way as well. And that repetition of, I'm feeling this way. I'm used to having my substance when I'm feeling down. So I'm going to have my substance. But then when the substance does nothing for you, it gives you that ability to go seek other like hopefully healthier options to help with that recovery from the substance.
Do people use naltrexone long term?
Yeah, they do use it long term, definitely. When we're starting any MAT therapy, we always want to come up with a plan of when we're going to get off the MAT therapy. It doesn't have to be a hard stop or anything like that. And I would always let people know who are starting it we want to come up with a plan, like a 6 month to a 1 year plan to start coming off of it, but that might not be realistic in 6 months to a year. But they do use it long term, but we would always, you know, look to come off of it eventually, like any medication.
Are there risks associated with staying on naltrexone long term?
Um, That's a great question. As far as I know, I don't know of anything off the top of my head of long-term risk right now. I'm not sure we even have a large population who have had it long-term enough to really identify, like if they started it when they were 40, what's it look like when they're 80? So I'll have to look into that actually. I don't know off the top of my head any major risk.
Okay, let's go back to suboxone. I've heard people say that suboxone, it's harder to get off of suboxone than it is to get off of heroin, for example. So I guess, first question, what is suboxone, Sublocade, Subutex? What are those used for specifically?
So that is a partial antagonist. So those are used they help with withdrawal when we use them a lot when they're coming in and they're detoxing, and it helps with cravings. It helps with some of the withdrawal symptoms. And then we continue it to help with the cravings and hopefully decrease the chance of relapse. And that is, like I said, a partial antagonist. So that also binds to the opioid receptor. Um, and it can have a positive effect because it is in the opioid class. So it binds to the receptor, it helps with the cravings, and then it releases. And they're a little bit different because Suboxone has like the naloxone with it. Sublocade is just buprenorphine. Um, so they have a little bit different components as well.
So who's a good candidate for buprenorphine?
A good candidate would be someone who uses opioids. They're craving after withdrawing. They are at risk of going out and using so this is a good one where it's their craving, we know they're at risk, they could go use, because opioids have, such a high risk of overdose. This is a great one to help come on board, decrease cravings, decrease chance of relapse, so that we can decrease that risk of going to relapse and overdosing. So opioid, like someone who's using opioids, and
And
even
how long do people typically take buprenorphine for?
they can take it they can take it a long time. There's not, I don't know if there's an average of time. And like you said, it is hard to come to taper off of. We do have some really great information now to help us taper off of it using naltrexone. So with all the new research coming out, with all the new different modalities, I think we'll see in the future there's a lot of opportunity to start it and come off of it faster. But some people will start it and they'll be on it. They'll be on it for a long time, indefinitely, even like start it and still on it, but not out using opioids from the street and
Right.
that. Yeah.
Yeah. There's some people that they might stay on it forever.
Yeah.
And that's one of the things that I've heard people say. It's like, okay, well, once you're on Suboxone or Subutex or any sort of buprenorphine, you might have to be on, it's harder to get off of. So what do you speak to that? What's your thoughts on someone not being able to get off of?
So I can totally understand that, because the partial agonistic activity, it's still an opioid. I can understand why it's hard, but we do, if someone's interest ready, seeking it out, we definitely have modalities to get them off of it. Using naltrexone, there's actually just this week I found a new like treatment plan to help people move from Suboxone to Naltrexone.
Okay.
And it's using low dose naltrexone. I think we had a little bit of a conversation. We were all talking about it at the clinic one day, but I found a new plan for it, and it's using low dose naltrexone, where you're tapering off the Suboxone and tapering up on the naltrexone. And a lot of psychiatrists are using it around the country and having great benefit. Where we're able to do that. So in the past, let me give a little detail. Right now, you have to come off the suboxone or the buprenorphine for about 14 days before you can start naltrexone, just decrease any chance of like a withdrawal syndrome from this buprenorphine. Well, with comfort meds like gabapentin, some other meds we can give that, we do give in detox. If you give some of the comfort meds during this, 5 to 7 day period while you're doing a cross taper, and then get them on that naltrexone, it might be a crummy week feeling wise where you're like, man, I'm withdrawing, but then you're on the naltrexone and then you can, that's a whole new ball game where, the opioids, they're blocked and you're not getting any effect. And then you can start that path of the recovery. So I definitely hear that it's hard to come off the Suboxone, but we do have new modalities that maybe people haven't tried yet.
And I know I've heard, especially years ago, people would say, well, they're not really sober. They're not really clean if they're still taking buprenorphine or if they're still on Suboxone. But really, it's like, okay, they take Suboxone or they relapse and die. It's like, for some people, it's harm reduction, and harm reduction, it's better than them going out and using, because they just can't, they're not able to find fulfillment in life without it, right? They're they're not able to get that to, I don't know how to medically explain it, but it's like their serotonin levels don't get high enough to where they feel the fulfillment, the happiness, the joy. So they always have the feeling of guilt, shame, and needing the solution, which the solution is Suboxone.
Yep.
It can soothe that, right? Or a drug.
Yeah, absolutely. It's harm reduction, and how I really love to talk about it, and I love to hear other people talk about it just like this. There's an underlying reason why the substance use started, and the substances didn't heal that underlying reason. It helped them survive. It's almost like the survival tactic of using these substances. Our nervous systems were created to keep us alive any way possible: fight, flight, freeze. So substances are a mechanism of that. And, that's the stigma that, I want people to get rid of, because buprenorphine, it may be an opioid. And yes, I've heard that as well. They're not really in recovery, or they're not really clean, but it can be not just harm reduction, but it can help them get into a state of mind to get to the healing capabilities of, cognitive behavioral therapy, learning meditation, learning all these ways to deal with your nervous system and live a healthy, fulfilled life, understanding your nervous system, getting through whatever not problem, but whatever it was that caused the substance to be so fulfilling. And dopamine really is one of the main neurotransmitters we look at, and substances can increase dopamine like over 1,000 times our natural levels. So it's such a great feeling, and it really feels at the time that, it all the problems are gone, and they're not gone. They're just covered up. So yes, buprenorphine helps that still get the dopamine, still kind of help you make it through the day. But then, these going to a rehab clinic, going to somewhere that helps you be in recovery, learning the other modalities that are really going to heal the underlying problem. And then if buprenorphine is what you need to get there, great. And then start that work. Great. Start the work. And then maybe you get to a place, now I can be on naltrexone, which is a little, it's different, like we talked about, and then continue to heal. And then I can get to a place where I don't need to, get my naltrexone shot monthly anymore. I'm healthy. I'm living life, and I don't think I need it at all now, because the dopamine levels are back to a plateau state, a natural level in the body. And I can kind of process life without substances. So I would love if that stigma of, medication assisted treatment therapy could just be gone forever, so that, people who could benefit from it won't hear that and feel like they're not clean, because that's another form of shame that can put someone who already might feel tons of shame, it can put them back because of these things, you know?
Right, right,
Yeah.
right. So what is, I heard an interview with Peter Attia and Andrew Huberman, and they were talking about supplements.
Mhm.
And and the first question, I don't remember if it was Andrew Huberman or Peter Attia. I don't remember which one said that when they have a patient in front of them and the patient wants to be put on supplements, the first thing they really want to know is, okay, tell me about the rest of your life. Tell me about your mental health. Tell me about the relationships in your life. How are your relationships with your significant other, with your kids, with your parents, with your coworkers, with your boss? What does your diet look like? Are you eating the right foods? Are you eating whole foods? Are you getting enough sleep? Are you exercising? So those are, it's almost like they don't even want to give any supplements at all until they know that that part of someone's life is dialed in. So let's apply that to mental health and addiction recovery. What are your thoughts on diet, nutrition, sleep, and toxic relationships to someone's mental health? And does that need to be addressed first, or should that be addressed second? Or tell me your thoughts on that.
Yeah, so I they all need to be addressed really at the same time, but it is incredibly important. We are, made, like I said, our nervous system is made to protect us, and all of those things affect our nervous system. So our neurotransmitters, our brain, our neurological pathways. The brain is such a amazing thing because it can constantly be changing. And if you're in negative, you have these negative aspects in your life, like toxic relationships or toxic food, or, not getting enough sunlight, that's all causing different imbalances in the body. So it is incredibly important to look at all of that. My belief on medications is that they are so beneficial to help, especially with mental health medications. They can help you get through the day so that you can continue the work in the areas that can really change and heal. Because medications, there's very few that heal anything. They treat symptoms, which is great because symptoms debilitate us and they do cause our quality of life to go down immensely. So it is helpful to have medications, but those underlying problems are what need to be addressed. So addressing them immediately when they come in for mental health support. And then if they need medications on board, we identify what can be helpful at this time and ensuring that they're continuing to get the mental health services, dietitian services, all those modalities that can really heal that part. So with sorry, this is a little bit of a tangent, but with like ketamine, that some of those that you talked about earlier, those are all showing such great benefit with changing like neural pathways in the brain. And those are helping, but what has to be done with the ketamine is therapy. So we want, the positive feedback to be coming with the medication so that underlying can heal. So I I know why they don't look at throwing supplements on first because they understand that belief of we have to heal the whole person, not just throw something on to help with a symptom.
So tell me about ketamine. What's your experience with ketamine?
So ketamine, I have more experience with the S ketamine. And so just a little tidbit. So ketamine it's like what we call a racemic mixture. The chemicals, they're like two mirror images basically, and they, because of their conformation, they combine slightly differently. So ketamine has a R enantiomer and an S. So S ketamine, which is that nasal spray you might have heard of, that one is just the pure S enantiomer. It's only one of the mirror image molecules. And that one I've worked with quite a bit. And that I've talked to patients who have a ton of benefit from that. Very resistant depression in a lot of these patients, and they have done it. And it's really one of the first modalities that helps them kind of lift that weight. that we hear about with people who have depression and really resistant depression. So, and the research about it that's coming out, a lot of big institutions are able to start doing research on it. And some really great things are being shown from the research that it is very effective. Long term, not sure yet, but short term, it can really help pull people out of a severe depressive episode.
Who is a candidate for ketamine therapy?
So right now, the only FDA approved indication is depressive disorder and major depressive disorder. A lot of medications are used off label. So I know that there's a lot of clinics who will do it for, substance abuse. There's some information coming out about its effect with substance use disorder and like PTSD. Usually the PTSD, they have that dual diagnosis of major depressive disorder when they're getting it. But there's a few different ones coming, clinics that are trying different things. But right now, the only FDA approved indication is major depressive disorder, depression.
Is ketamine therapy addictive? Is ketamine addictive?
It can be if it's not used appropriately. So the dosages and how we use it now, it's not. So it's a high dose, high doses, it can be addictive. Yeah, you can have that risk there, but because it's only given by providers in a clinic, there's less of a chance that you're going to be getting a dose that you get addicted to. I have had experience with people who have done ketamine therapy and zero cravings for it. It's just the positive benefit of kind of the sorry, I'm blanking out, the positive benefit of the new neural pathways having more positivity and less of that weight on them. So I don't have experience with anyone becoming addicted yet, but it is a medication that does have a risk of addiction.
And how does one build new neural pathways while using ketamine?
So the theory behind it is that it can bring you into a state of almost like acceptance of the reality. So, you kind of decrease that shame. You don't have those feelings of shame. You can come to more of a surrender almost. And the theory is that with that on board and being able to be at a level of surrender, and then you can do cognitive behavioral therapy or psychotherapy and with a guided expert who can, or with an expert who can guide you through it and help build those new positive neural pathways, like changing brain thoughts of, instead of having the negative thoughts all the time, learning to have the positive thoughts.
Okay. Let's talk about methadone for a minute.
Okay.
What are your thoughts? Do you ever prescribe methadone? What are your thoughts on methadone?
No, so methadone is mainly used at methadone clinics. Specifically, I don't work in any methadone clinics. I've never prescribed methadone or worked with any methadone prescribers specifically. I think that it can be a really helpful harm reduction tool. And that's really the most I can tell you about methadone because I don't have that much experience with methadone in particular. I think methadone is one that you start and then that one's a little bit harder. I don't know the tapering process from methadone to buprenorphine or methadone off methadone. So I don't use it. I think I personally would shy away from it because I think the other modalities that we have are a little bit more beneficial. You don't have to, and more accessible. Methadone is like you have to go into the methadone clinic every single day.
Right.
You have to jump through all these bridges. And like I said, it's a good harm reduction tool, and there are people who can benefit from it, but the accessibility it's not as easy as the other two. And they're all, I will say, they all show they're non-inferior to each other. So I would say using one that's easily acceptable over one that's not, if the clinical trials show that they're non-inferior to each other, meaning, methadone isn't more helpful compared to buprenorphine. I would just go for the buprenorphine because the accessibility, or the naltrexone because of the accessibility. So yeah, not too much detail about methadone. Sorry.
Okay, we're kind of. I got one more question. What's your what is your goal or your vision in continuing to provide medication assisted treatment? What do you get out of it?
Like I said earlier about why I came into it, I know that growing up in dysfunction can lead to substance use. And I I want people to know that even if they, I've heard this is saying it just because you were born into the fire doesn't mean the whole world is on fire. But that perspective, you can be stuck in that perspective. So with medication assisted treatment, the whole goal is to help people recover because I think at the end of the day, a life in sobriety, uh, you is very beautiful. And I think it's hard when you're on one side of it to see the beauty, but when you get to the other side, you're living in beauty and happiness and joy. And I want that for everyone. So I really believe that these are modalities that can help people get there. And working on integrative teams with these modalities can help people get there. So that's just my end goal is, helping as many people get to a healthy, joyful life that I can.
Awesome. Awesome. What's the goal of Camelback Integrated Health and Wellness?
Our goal is just that helping people um, who are who have mental health, who need mental health help, and who need help after they've been through like a recovery program, who need help continuing that support. That's what we're there for. We're there to support them and help them with their T therapy, help them with their mental health services, help them with their we have dietitian services, so therapy services, everything that we believe you need for support to be in recovery, stay in recovery. That's our goal is to just support the recovery process.
Who's a good candidate for Camelback Integrated Health and Wellness?
Everybody. No, good candidates. Anyone who needs mental health support, we are going to be doing things like ketamine. So anyone who needs mental health, it doesn't have to be someone who specifically has had a substance use disorder that they're in recovery for, but so anyone with mental health, and then also people who have been in a recovery center and now they're just looking for that extra support to stay in recovery. They're also great candidates because we have all the support to continue their clinical services after they're not in this vacuum of, recovery and recovery houses. So
Right. And so Dr. Robbie Westerman is also Next Step Recovery, Camelback Integrated Health and Wellness, aka Next Step Recovery. Really, it's the next step.
yeah.
It's the support after someone's in the bubble, right? Someone's in the bubble, they're in inpatient treatment, they're in an outpatient treatment program. And normally what happens when someone leaves one of those treatment programs is their case manager says, okay, go out, find yourself a doctor and continue seeing a therapist. And then and more often than not, they don't find continued support and they relapse and they're back in rehab. So with Camelback Integrated Health and Wellness, the intention, the goal is to help people after they've been through some sort of a program. They don't have to have gone through a program, but after they went through a program, it's like whether they see us or see you weekly or monthly, and that support can be for a few months or a few years.
Yeah.
It's continued support because
That,
we all know someone that's in their addiction for 3 years, 5 years, 10 years, 20 years, going to rehab for 30, 60, 90 days is a good start. However, the path of least resistance when someone gets triggered, when someone feels restless, irritable, discontent, the the path of least resistance is to go back to their drug or their whatever it is, their drink, their drug, their behavior.
yep.
And so finding that support and sticking around with us is going to help them. The goal is to help people achieve long-term, lifelong happiness and freedom and recovery.
Yep. Absolutely.
Is there a question that I missed? Is there a question that you have in your mind that you wanted me to ask you?
No, you covered everything. Yes, I'm so glad we got to dive into all of that with the MAT and the stigma and everything. So I think you covered it all.
Okay, awesome. Okay, one last question.
Yeah.
Tell me about your morning routine.
Okay, so I have 2 kids, so, this morning routine can get a little chaotic, but I always wake up.
How old are your kids?
I have an almost 2-year-old and I have a 6-year-old.
Okay. Okay.
So, I get up every morning, I drink water wash my face because I'd love to, like, do a cold plunge or something like that, but there is no time with a 1.5-year-old. So, um, I drink water and then I try to spend, before anyone wakes up, hopefully, spend 5 to 10 minutes in, like, a meditative type of situation. Sometimes it's only, like, I can do, like, a quiet journaling, but I try to do, like, a 10 minute quiet meditation, and then by that time, it's like clockwork. Someone senses I'm awake and they're up. So it has to be a pretty quick morning routine, but I do have one because it is so beneficial just to get the day going on the same thing. And yeah, and then after that, it's just whatever the needs are of the little human. So
Yeah, yeah, you got the kids. I mean, I'm sure that throws a curveball to the morning routine. I mean, I know my morning routine is just like if I don't follow through with my morning routine, my day's kind of off. So
yeah. Yeah, I feel the same way. It's almost like if I forget to drink water and I drink coffee first, the day's totally different. So it's always in my mind, like water before anything else, and then 10 minutes of hopefully quiet time. And then once the kids are up, it's like all the coffee.
forget it.
Coffee.
Yeah, forget it. Forget it. Okay,
Yeah.
awesome. Okay, where can people find you, Taran?
You can find me. I'm one of the people in my generation that doesn't have a whole lot of social media, but you can find me on LinkedIn, just Taran Goodballot. That's really the main social media that I have. And I do check that one regularly. So if anyone wants to reach out, ask questions, anything like that, I can definitely find you on there if you message me on there.
Or they can find you at Camelback Integrated Health and Wellness.
Yes, that's true. I was thinking more of the social media side because the technology world we live in. But yes, Camelback Recovery, Integrated Health and Wellness. Exactly. That's where I'm at. So
Awesome, awesome. Okay, that does it with our time with Taran Goodballot. And before we end this episode, I want you to go to the review section on iTunes or comment on YouTube, Instagram, Facebook, wherever you're watching. Type in the one thing that resonated with you. Every comment counts, and what you share could resonate with someone else that is struggling and potentially save their life. So go ahead, share the one thing that resonated with you. It'll take just 60 seconds out of your day, but what you share could not only save you, but it could also save someone's life. And that does it for the week. I'm Tim Westbrook. I hope that our paths cross again in the next episode of I Love Being Sober. Taran, thank you so much. I appreciate you. And that's it for this episode.
thanks, Tim.
If you found this video to be of value, be sure to like it, subscribe to our channel if you want to see more videos, leave a comment if you have a question, if you've got something to say. Camelback Recovery provides treatment services for people struggling with mental health, mental illness, addiction, alcoholism. So if you or someone you know is struggling, be sure to reach out to us. You can go to our website, camelbackrecovery.com, or our information is in the comment section below. And we provide everything from detox, inpatient, outpatient treatment, sober living, recovery coaching, sober companion services. So either we'll be able to help you or we'll be able to refer you to people or treatment centers that might be a better fit. So I will see you in the next video.